Just to let you all know that Dr. Amit Hora is also just joining. He is also our cardiologist, especially for the pacemakers and electrophysiological part. So there is some part that we have covered in the end in this also. Just to let you know on the journal reviews, just 2 journals which were there because it is all about interventional cardiology and critical care together, which we are facing nowadays too much with the complex cases that we get and we manage in the ICU. So 2 of the journals, one was from the intensive care journal, which was the Journal of Intensive Care, which in 2023 has given a broad review on how to manage the patients who come with cardiogenic shock. And one of the journals, which was in Frontiers in Cardiovascular Medicine, which has also reviewed on the current and the future options for adult biventricular assistance, some of them which we are already using in our day-to-day practice at HN. And some part which we are going to cover is on the structural heart interventions which are performed at our hospital and how we manage them. And lastly will be on the new things that we are going to learn in pacing, which is one of the things which will be covered with the Amit Hora. So I would like to just share my slides so that it is just to make it easier for all of us to see. I hope you have seen. So to start with, the first topic, as I already told this, I'm not going to repeat it, management of cardiogenic shock. So we know that the American Society of Cardiovascular Medicine with cardiovascular interventions experts has published a consensus statement and that has put up a SCAI shock stage classification. We have not been using it, but while reviewing everything, I came across this checklist which has parameters which can be used at the bedside and which is something which we are going to show you. The types of mechanical circulatory support devices which we have to decide and when we have to decide, and just an overall approach to a patient from the ER who comes on, which are the devices which can be used for this patient, especially the patients who come with either with the MI with the cardiogenic shock or a patient who has had a cardiac arrest, and we have to put up some of the support. So over to Maulik on starting with the classification checklist for the shock, cardiogenic shock. Maulik, are you mute?
Yeah,
Maulik?
thank you. Yeah, I'm there. Yeah. Thank you, Darshana, for the introduction and setting the stage for this discussion about interactions between cardiology and basically interventional cardiology and the critical care and the year in review. So this slide, what we want to discuss is about the SCAI classification that has come about classifying and basically trying to triage cardiogenic shock patients into categories, and in which category you may need to preemptively think about the things that like a mechanical circulatory support or early revascularization or some other reason. So this classification basically categorizes the patients into at risk of cardiogenic shock, beginning of cardiogenic shock, C is classic cardiogenic shock, deteriorating, extremis, that means almost end of care, and arrest. This six categories. So, I mean, I wouldn't want to go through the whole thing, but what is important is the physical exam and biochemical markers and the hemodynamics, these 3 parameters. So, JVP, well-perfused peripheries, strong distal pulses, normal mentation, and clear lung sounds. This is what you expect in a healthy patient who has some symptoms which is exposing the patient to cardiogenic shock like acute coronary syndrome or precipitating heart failure or something. But patient is still not in heart failure and not in cardiogenic shock. In these patients, you can also find normal lactate and normal renal function. Obviously, the systolic pressure is more than 100, cardiac index more than 2.5, CVP less than 10, and wedge pressures of less than or equal to 15 are expected in these patients who are not yet in cardiogenic shock. Things start getting a little difficult when you see elevated JVP and strong distal pulses, but hypotension. These patients are systolic pressures are below 90, MAP are below 60, and heart rate, they are becoming tachycardic. So tachycardia, hypotension, these are the classical signs, elevated JVP. And on biochemical parameters, you see normal lactate, minimally or just slightly deranged renal function and elevated BNPs. These are the patients where where you have clinical evidence of hemodynamic instability without any signs of hypoperfusion. And so these are the patients where we would want to kind of sometimes pick them up early and correctable factors. Then comes the patient who is in classical cardiogenic shock, who has hypoperfusion requiring intervention like pharmacological or mechanical beyond volume resuscitation. These are frank signs of volume overload, altered mental status, cold and clammy extremities, and urine output less than 30 ml per hour. Lactates are uptrending, renal function is deteriorating. There is congestive rise in the LFTs and elevated BNPs, and wedge pressures are more than or equal to 15. And stage D and E, they typically talk about profound or a cardiogenic shock which is kind of worsened and not attended in the initial time. So we will not talk about that. But this is the basics guideline. And if you see even a basic ICU or ER, doctor can kind of just tick these things. And whichever category the patient, you find most ticks, you kind of triage a patient and start thinking about a recoverable or reversible cardiological condition, or a next step, that means a circulatory support device or IBP or whatever. So I would like to ask Dr. Menon, sir, what do you make out of this classification? Does this make sense? Does this make us any wiser? Because I think these are all the things we see anyway. Does this make us any wiser, and is there a value in adding this to our triaging of cardiac patients who are like a precipitant cardiogenic shock or in cardiogenic shock?
See, I think basically triaging, triaging will require certain definitions of how these patients present. But I think more than anything else today, what you require is a sense of clinical acumen in terms of getting diagnosing these, or even preempting these even before it reaches a class C or a class D level. So waiting for blood reports and waiting for certain other parameters to show up may be a bit too late by the time you start treating a patient. So for me, the first column in terms of description and the physical examination would be the prime markers. The biochemical parameters can be anything. But I think, yes, we can go, but we can use these as as certain criteria, but we don't have to necessarily follow each of these in terms of how to step up the dynamic support, because each patient is different. What you may require in a certain specific subset of patients is different from what you may require in a chronically stable, a chronic heart failure patient. So because those patients may sustain certain things of certain levels of injury much more than an acute patient. For example, an infarct patient, you may need to go up into supports much earlier to prevent a problem rather than treat a problem. So while these checklists are meaningful, but I think they should be a guideline, not the gospel to be followed.
Yes, I fully agree, I think, on that point. Nihar, you want to add anything on this?
Yeah, I think Sir has said it quite well, because when you have a judgment of a person worsening, it's better to go into advanced cardiac support maybe 15 minutes, 20, 30 minutes early as compared to 30 minutes late. And that won't allow you time to wait for worsening renal function and worsening LFTs. So like Sir said, that the clinical judgment of a worsening patient, cold clammy peripheries, dropping pressures, increasing inotropes, output, urine output is such a simple and important parameter that we should monitor. All these things should lead to an escalation of therapy earlier, more based on the clinical evaluation, with supplementation of all these other parameters in the biochemical and hemodynamic list.
Okay, Darshana, I think these are the good takeaway points from this slide and this classification, which can use to triage patients, or rather categorize patients, and also to risk identify. But clinical acumen and picking up physical signs early will definitely help prevent the progression of the patient in the next category and treat them better. So I think we can go to the further slides, Darshana.
Yes. So going further, basically, we know the basic treatment of the shock has to be started either at the ER level or at the ICU level. But going forward to what is our discussion in interventional cardiology is all related to the biventricular assistance devices that we have we have come across. And I think Malik can take forward from there on biventricular assist devices. What are the devices and what can be used in where?
Yeah. So patients who require mechanical circulatory support is basically what is important here is to identify what is the end game, because there could be a patient who is having an antiviral MI or has multivessel complex coronary artery disease and a surgical turn down, which needs both these patients are going to require a short-term support for the left ventricle so that the kidneys don't stop functioning, and they give us a window to kind of maintain perfusion and treat the primary cause and stabilize them. So basically, a very, very short-term procedural support kind of a thing. Second is a category where you need a support device or a mechanical circulatory support device as a bridge to recovery. A cardiogenic shock patient who has been treated already and not doing well. Let's say anterior MI who's presented late, you've done a primary angioplasty, but EF is very, very low and patient is not recovering well. I mean, Darshana would know this. Last night itself, last midnight, we did one such Impella in Pune. A patient who's anterior MI, LED, plasty done, but 12 days not recovering. So this is a kind of a bridge to recovery or possible bridge to transplant. And third is a destination therapy, where you know that patient is not a candidate for a transplant, not a candidate who is going to recover and going to be off the pump or the device, and you give them as a basic device which is patient going to live with. So based on this, we can talk about the devices. So for support for during procedures and acute crisis, and as a bridge to recovery, which is like maybe a week or two, IBP and Impella. And now we have Impella CP, which can give up to 3.5 to 4 liters of cardiac output through a 14 French transfemoral percutaneous sheath. Is a great tool to the armamentarium. And there are trials to suggest that it has benefit in acute cardiogenic shock undergoing procedures and as a bridge to recovery. Although there is some controversial data on that, but we have all seen examples. And as Dr. Menon rightly said, each patient is different. So Impella and IBP are the devices which can be used as a kind of a short-term or a support device. In a mid-term or I would say bridge to recovery kind of a thing, where you're looking at a longer period of recovery, tandem heart, ECMO, or HeartMate. These are the available devices that we have with us, and a CentriMag, obviously, which are available in India. A lot of these are not available in India, but HeartMate 2, HeartMate 3, ECMO, obviously, we have available, and CentriMag are the devices that are available with us, but they require surgical intervention. That I mean that they are to be implanted by a trained team in the OT, and they are the ones which can be used as a little bit of longer period, let's say 15 days, 20 days, or sometimes even a month. And HeartMate is a easily available device in India, which is the most experienced in India, which can be used as a destination therapy. That means patient goes out of the hospital with HeartMate and lives on that, not destined to undergo transplant, not fit for transplant or any other definitive therapy. So I think these are the biventricular assist device that we have available and we can use for patients which have certain indications like what we just discussed. So Dr. Menon, any take on this from your side, basically, especially on procedural and short-term recovery, and what do you think they are useful and the benefit?
I think in any of these devices, we are looking at two, three things. One is the cost involved in the procedure.
Yeah.
Because most of these devices that we talk about, whether it is an Impella or an ECMO or a tandem heart or a CentriMag or a HeartMate, they are all very expensive. How many patients can afford these devices? A simple thing that we can always use in our patients in terms of acute episodes or in the cath lab, etc., is an intra-aortic balloon pump. It is an underestimated instrument, but sometimes gives you a lot of support in terms of treating patients. Yes, the Impella has changed the way we treat patients. Impella is something which we can keep it short term. We can keep it over a period of few days, and we can again that's something which helps the left ventricle. In terms of right ventricular support, you have the ECMO. In terms of lung support, you have the ECMO. But again, I would like to reiterate that timing is of most importance. As long as you as you implant these devices on time, you will get the requisite benefit. Once other organs start failing and you use these instrumentations, nothing is going to help you.
Maulik, one question if I can ask about Ajit Menon. Sir, I have seen that even for the high-risk complex procedures, you take a call on, Impella or something as a support. How do you choose this as a support? Like I have seen one of the patients post it tomorrow also, and I've seen you doing it in the past also. So how do you do that decision making?
I think that's a very good question.
If the LV is severely dysfunctional and you have a lone, if you have a single vessel which is supporting the heart, and you think the risk of arrhythmias or the risk of cardiac arrest is very high, then an Impella is definitely much more beneficial than an IBP. An IBP will only support the circulation. It is not going to do anything if the patient goes into a cardiac arrest or a VTVF. Here we have a situation where even if the patient goes into a ventricular tachycardia or a fibrillation, you still have the support of the circulation, and you have enough time on your hands to revert the rhythm, to take care of the vessel, and complete your procedure at the same time. So there are certain situations where an Impella is definitely beneficial and probably something that you can't do without. And there are certain situations where you can probably make do with a IBP. But again, there are various trials that show that IBP is not beneficial, though in our clinical practice, we have found that use of an IBP in a lot of situations is definitely supportive.
I think what Sir said, and Darshana, if I can put it in one line, if you have an Impella, I know it's a very expensive device, but this high-risk PCIs and all, sometimes if you have Impella support, patient who is actually fibrillating or not fibrillating, but has ventricular tachycardia also, you can kind of continue the procedure without worrying about the arrhythmia, and that gives a great sense of comfort and time to finish the procedure.
Yes. So
you don't have to go on CPR and cardiac massage while the procedure is on. The Impella takes care of it. Of course, you treat the rhythm abnormality. That's different. But you are rest assured that the circulatory status, the kidneys that don't suffer, the brain doesn't suffer, and your at least your mean flows are maintained with the Impella.
Yes. So going forward, just a little review on, just a little catch up on for those who have participated, especially from the critical care also, where Sir has highlighted and Maulik and even Nihar has highlighted, just an approach which can be done to a patient who comes to the ER. And, if we stage the patient properly on what is required at what point of time, it can help us easily in bringing good outcomes for the patient. And this actually starts from the ER itself, from the ER to cath lab to ICU. So, Maulik, would you want to go ahead and just discuss on that?
Yeah, I think it is just stressing upon the same algorithm that we discussed. And it's about triaging the patients as soon as they reach the ER and having a shock team which is capable to get and which can enable even an institution of a mechanical circulatory support within no time once the code is activated. So ECMO or eCPR ready team, a shock team, which assesses the patient, looks at all these objective parameters that we just saw in that algorithm, and based on that decides about the further line of action. Obviously, the CPR and if required, an ECMO-based CPR, that is eCPR, and all this starts if the patient has a cardiac arrest. And once you have a return of spontaneous circulation, a VA ECMO is the easiest thing to do as a bridge to next step, which could be an angiogram. And deciding on based on angiography, you can decide about whether this patient needs urgent revascularization with PCI, and you can put an Impella or IBP and do a PCI, or you can do a ECMO with Impella. It's called ECPella. And unload the left as well as the right heart at the same time, which gives you a window to not only do a procedure, but also maintaining end organ perfusion and deloading the heart. And once you have achieved that, then the work goes on to say a very complex index that is cardiac power output, which is basically a derivative of cardiac output and maximum vote achievable on a mechanical circulatory support. I think I will not go there. But so this is the algorithm that they have suggested based on the ER, cardiac cath lab, and coronary care unit. And if we can see, they have very, very clearly categorized stages A, B, C, and D, E, which stage of cardiogenic shock and what kind of support you can give here. So that's a way to kind of address these patients. But again, the decision remains a lot of times based on the individual patient and also the cost aspect involved, because these are extremely expensive mechanical circulatory support devices. But I think we should be very happy to say that we at least have the shock team in place, which can institute an ECMO or an Impella, even if you want to during a crisis situation. Nihar, you want to add something to this algorithm, or your take on this?
So I think Maulik has covered the points well. I think the thing is that you can, when you've activated the shock team, it's important that accesses are taken as early as possible. We should not shy away from taking multiple accesses. If today we are doing a angioplasty through the femoral, having opposite side accesses which could be used for an IABP or an Impella is a very useful thing, because once you started, when a patient has low hemodynamics and you've heparinized the patient, after that to take in these large bore accesses sometimes gets very challenging. So when you have a patient in this borderline category where you don't know if you want to or not get hemodynamic support, number one is take accesses and take keep these backups available, activate the correct team so that they are on standby. Second would be that we can change our decisions for therapy, like this chart nicely shows, when to go for IBP, when you can go for Impella, like Maulik nicely said, whether we want to do an ECMO and add an Impella to this. All these things are dynamic, and at the top where it says the team has to take a decision, it's a very important thing that the team takes a call as to how the patient's hemodynamics are and when you need to escalate, de-escalate, and keep things fluid.
Okay. Yeah. Good point. Yeah.
Shortage of time, I think we would just.
Yeah. I think you go to the next slide.
Next thing which we would like to go ahead is with this. This is, I think, something which we all know, the complications which we have.
Yeah, this is okay. I think Darshana, we can go to the next.
So the structural interventions that we come across. So the patients who come post. These are the another complex cases which we come across in our ICU after this interventions. And so Maulik, from your basically. The team would like to these are the patients who can develop certain complications and they require a close monitoring, and that is something which if you can highlight on in the next one also, so you can just go ahead with that.
So I think this transcatheter interventions for valve replacements or valve repair are a new kind of not new but relatively newer set of interventions. And it is important from ICU point of view that the ICU team knows what the doctors are doing in the cath lab, because you can only monitor a patient well for the expected set of complications if you know what has the patient undergone. It's like when the patient comes to an ICU after an angioplasty, the intensivist or the ICU registrar knows what has been done. there was a blockage, it has been opened, what to watch for. We use dye in the angioplasty. All these things they know. So here, I think one important aspect is the sensitization of the entire team about the procedural aspects, number one. And next is this slide here. Yes, Darshana, thank you. Where these are the possible complications that you may encounter in ICU in the first 24 to 48 hours after this large bore valve replacement or valve repair procedures. Whether it is post TAVR fever, one episode, which is very common and does not need any attention, or rhythm disturbance, because many of these valvular procedures associated with conduction disturbances or CHBs happening in the later part of the ICU stay, cardiac tamponade, a stroke or any minor or major cerebrovascular events, any vascular complication, delayed bleeds or vascular limb occlusions, etc. Post-interventions, delirium if the patients are sedated, any device-specific complication, and also the kidney part, because these procedures sometimes use quite a bit of dye. So these are the various interventions that the ICU needs to be aware about, the critical care team, and these are the set of complications they need to watch for. Dr. Menon and Dr. Nihar, I think one point on anything on this thing where the ICU comes into play, the critical care team comes into play.
So, I'll just, from the critical care point of view, the large bore accesses and their management becomes very important. And the way the critical care team manages it post procedure is really important. Small, simple tips are actually very similar to how we do even after angioplasty. But here, for example, you should know that usually there are two femoral arteries which are accessed for a TAVI, for example. Sometimes it's now moving to radial and femoral. It's important monitoring the pulses distally, because one of the most important problems are distal pulses and either thrombotic or dissections and complications related to the vasculature. So keep looking at the groin and monitoring the pulses. That would be number one. Number two is look at the ECG, because a lot of these patients, especially after TAVI, can develop late heart blocks and bundle branch blocks. So keep looking at the duration of the QRS and look for subtle bradyarrhythmias if they get any. And then, of course, the other routine things, which are the urine output, the blood pressure, these things we all do monitor in the ICU regularly. But I think the rhythm and the pulses and the groin, these couple of things, if the ICU keeps looking at, it really prevents most of the common disorders. And of course, lastly, is talk to the patient, because strokes are very subtle, but they do happen in a lot of structural interventions. So talk to the patient, keep chatting with them, so that you know that if there is any change in their mentation, that's an important aspect as well. And all strokes are not motor strokes; they may be subtle and cognitive strokes as well.
Dr. Menon, anything from your side?
No, I think nothing more to add. I think you guys have spoken about most of it. I think what I would expect in an ICU, most of the complications that happen on the table or immediately post procedure. What you look for in the ICU are probably rhythm disorders. Watch the urine output and watch out for vascular complications in terms of either groin bleeds or vascular occlusions.
Okay, Darshana.
And one thing to all intensivists is when you have a groin bleed, remember the puncture site is not the site of the arterial puncture. The arterial puncture is at least 3 to 4 millimeters above where your groin puncture is. So the pressure should be much higher than on the this thing. So
okay. So Dr. Vora is there? Is here? I can't see. Okay. So I think, Darshana, if you don't mind, I will take this slide.
Yeah, go ahead, please.
So last slide is about the conduction system pacing, where Dr. Vora was wanted to step up on this fact, where a lot of patients who have heart failure and nothing can be done for the left ventricle, which is dilated or which is dysfunctional, and there is a recurrent heart failure. So these patients, we all know, can undergo a CRT, the cardiac resynchronization therapy, where you can, make a broad QRS from LVEB into a narrow QRS and synchronize the pumping of the heart and increase the effective forward output. But also, there is something called as conduction system pacing. That means that any patients who, let's say there is a 75-year-old guy who's come to ER with a complete heart block, or there is a patient who has developed CHB after TAVR. All these elderly patients have stiff ventricles. And when you do a standard conventional dual chamber pacemakers, you will implant the RV lead at the apex or in the distal part of the septum. So they invariably develop a pacemaker induced LVVP. So we are making the rhythm synchronous, but we are giving them left bundle branch block, which itself depresses the cardiac output. So with now recent devices and techniques, you can do the ventricular pacing right at into the conduction system. That means at a place where in the proximal septum, before the division of right and left bundle. So that means even after pacing, the QRS remains narrow and the ventricular synchrony does not get disturbed. So all these patients who are elderly and they may need a pacemaker for whatever reason, if you can offer them conduction system pacing, you are preventing something called as pacemaker syndrome. That means pacemaker induced dyssynchrony, ventricular dyssynchrony, and resulting failure. So this is one of the aspects of conduction system pacing. Dr. Menon, you want to say something on this?
I think Amit has joined. So why doesn't
Oh,
Amit?
great.
Yeah. Dr. Vora has just joined.
No,
Yes.
so yeah, I think Maulik get a proper overview in terms of the new modality of pacing. So what we want to do is basically mimic the real conduction system activation, because if you have a real conduction system activation happening with a pacemaker, then it will have a synchronized activation of both the cardiac chambers and it will work very well. So I think we often have patients with LV dysfunction in whom we have to put a dual chamber, a pacemaker because of AV conduction disease. Now, with the conventional system of pacing in the right ventricle, the chances of LV dysfunction may worsen. And also in some patients with normal LV function, putting in a conventional pacing lead in the right ventricle induces LVBB related LV dysfunction. So I think the new in thing is to engage the conduction system. So what we do is that the ventricular lead, we place it in the ventricular septum and we try to go deep into the ventricular septum and engage the left bundle. So now the leads will probably, on an X-ray, if you see, the leads will look at a very odd location, very high up. These leads are much thinner leads, and it may, on the ECG, should show you completely like a normal QRS. So you won't even make out that this is a paced ECG. That is the aim of conduction system pacing, so that lead penetrates from the right ventricular endocardial septum deep into the septum and exiting towards the left bundle branch block. We engage the left bundle branch block. That helps into left bundle branch. That helps to negate the dysynchrony part, and the activation is synchronous. So I think this is something which is being done more and more frequently and becomes much more relevant in people who have a pre-existing LV dysfunction. So I think it's important for the intensivist to know on an X-ray or on an ECG that this is the new modality that we are doing. Otherwise, you will find on an ECG the QRS looks absolutely like any other normal ECG, and you would wonder whether it's pacing or not pacing. But that's because we are engaging the conduction system, and also the X-ray image may be completely different. Now, these new systems always have a higher chance of kind of dislodgement. So they tend to, the dislodgement rate is slightly higher as compared to the conventional system. And therefore, immediately post procedure in the ICU, what you need to keep a close watch is in terms of lead dislodgement and sudden bradycardia not happening.
Noted, sir. Fine. I think the last thing which, Maulik, this is something which you really wanted to cover on the vascular closure devices related monitoring. Maulik? I think Maulik, you're on mute.
Oh yeah, I was on mute, sorry. So I think we have covered this majorly. There are two types of devices which we commonly use to close our groin puncture sites. One is a angio-seal, which is on the right side of the screen, which is basically a jelly, which goes inside the artery and like kind of makes a plug in the anterior wall of the artery on the puncture side. That is one. So this is an intra-arterial device. That means this plug or jelly can get embolized if it is not very nicely sitting there and cause distal flow obliteration or distal limb ischemia. This is with angio-seal. Second is a suture-mediated device, which is the ProGlide, which is on the left side of the screen, where we kind of, before putting the sheath, we put the ProGlide and we make a lasso, kind of a stitch, kind of a noose or lasso, which after the procedure we tighten the lasso, so the puncture site becomes like a and closes. So this is suture-based device. There is no intra-arterial jelly or plug, but again, this can have a problem of sometimes the stitch not closing the hole well, so patient can still keep bleeding, and two, sometimes stitch closing the artery completely, and there could be a distal limb ischemia. So these are the two things that we want the critical care team to know, that after any vascular closure device mediated closures of femoral arteries, after angioplasty or after TAVR or after any procedure, we keep looking for subtle oozing, hematoma formation, and distal pulses. And these complications typically happen in first 2 to 3 hours. If it is not happening in first 2 to 3 hours when the heparin effect is maximum, they usually don't happen. So this is what exactly I wanted to cover. I think we are okay there, Darshana, or you want to?
No, I think we have covered everything very well. Anyone wants to add anything?
Yeah, anyone wants to say anything on this part?
That's it. So thank you, everyone. Ketan, you can take over. Thank you, sir, Dr. Ajit Menon, Dr. Amit Vora.
Thank you. Thanks.
For giving this.
Thank you, sir. Thank you, Nihar. Thank you, Dr. Menon. Thank you,
Thanks.
Dr. Vora.
Thanks.
Thanks.